This video presentation is copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of this video may only be undertaken with the prior written consent of the AARC. This presentation cannot be resold, distributed, or displayed for profit. Copyright 2014, all rights reserved. This program is supported in part through unrestricted grants from Boehringer Ingelheim, Sanofian Pharmaceuticals Incorporated, and Monahan Medical Corporation. The following is a presentation from the American Association for Respiratory Care. Welcome to today's presentation. Reducing Unplanned Hospital Readmissions, an Opportunity for the Respiratory Therapist.
Hello, my name is Tom Kallstrom, and I'm the Executive Director and Chief Executive Officer of the AARC. I'm also a registered respiratory therapist. From the AARC, I want to congratulate you for having the foresight of learning more about Patient Protection and Affordable Care Act and the issues that are surrounding 30-day readmissions for COPD and the role that you can play in reducing these preventable readmissions. Now, as you know, the Affordable Care Act has essentially reframed how patient care is being reimbursed, and thus, in many instances, how that care and transition out of the hospital occurs. As a result, there is an opportunity for clinicians and respiratory therapists specifically to participate and lead in new approaches in patient management, specifically dealing with the COPD population of patients. There rarely comes an opportunity like this, and we urge you to spend the next 60 minutes to learn how you can be a part of this effort. Now, joining us today are Dr. Stephen Jencks and Becky Anderson. I'd like to welcome you both today.
Thank you, Tom.
Dr. Jencks is currently a consultant in healthcare safety and was the senior author of the authoritative New England Journal of Medicine article on readmissions and Medicare. He also served as an assistant surgeon general. Becky Anderson is a registered respiratory therapist and manager of the disease management section of respiratory care services at Sanford Medical Center in Fargo, North Dakota. None of us have any conflicts of interest related to this presentation, and any use of brand names is not meant to imply an endorsement of any specific products. So let's get the ball rolling with Dr. Jencks, and I'd like to ask you if you could break down the hospital process for us.
What I think we have to start with, Tom, is an understanding that for a patient to be readmitted, they are discharged, they receive a little or a lot of ambulatory care, they come back to the emergency room for some reason, and they are readmitted. That's at the minimum a four-step process, and we're today just focusing on what goes on in the hospital that leads up to the discharge into the community. The best summary of this, I think, comes from Eric Coleman. And Eric said that in order to have a successful transition, you need to build on four pillars. The first of these is that the patient and the family know what medications to take, why to take them, what the side effects are, and finally, that they can actually get the medications. The second pillar is that the patient knows what Eric calls red flags. That is, clinical conditions which are a warning sign and which should lead to contact with a clinical source of help or advice. That includes there being a telephone number to call, and it also includes the idea that that telephone number is not the phone number of the emergency department of the hospital. The third of Coleman's pillars is that the patient has a follow-up appointment, intends to keep the appointment, and is able to keep the appointment. the follow-up provider knows what has happened to the patient recently. The fourth of the columns is that the patient has written materials that include a record summary and a plan for care. Now, it'll occur to you that these are not revolutionary ideas. We would think of them as standard care. But if you think about your own experience and those of relatives who've been discharged from the hospital, I think you will find it easy to understand that this does not happen reliably today. So, in order to think about how to get there, I think we need to deal with four key ideas. The first of these is that words matter. We have gotten into the habit of using words which misdirect our efforts. I'll come back to what that means. Secondly, it's very important to know where the patient is going. The third is that it is important to understand teaching and care planning with the patient as an integral part of making the patient part of the care team. And the fourth is that without checklists, it's very, very hard to do the complicated things that need to be done. So let me start first talking about the ways in which words can matter. Briefly, we often speak of the need to try harder. We need to speak of changes in the system which will make it easy to do the right thing and hard to do the wrong thing. A second example is our use of the word discharge. And you'll notice that I've used the word several times, which is sort of course, deliberate on my part to make clear how hard it is to abandon the use of the word. But it's not a good word because it really reinforces the idea that the patient ceases to be the hospital's problem when they are discharged, which means when they go home. The third is the use of the word non-compliant, which as a label for a patient makes it almost impossible to envision the patient as an active, positive part of the care team. And finally, we need to get away from the term unnecessary readmissions because nobody's quite sure which readmissions are necessary, and instead to talk about unplanned care because unnecessary admissions are almost always unplanned, and we can certainly tell what's unplanned. Now, the essence of the problem that leads us to talk about system change is that we simply do not do what we intend to do under normal circumstances. You'll hear some details on this from Becky in a few minutes, but for example, we may imagine that we do something with high reliability, and when we start to collect data, we think the data must be wrong because it suggests that our reliability is very mediocre. The care needs to be reliable. There are real problems with people carefully doing the wrong thing, but there are much larger problems with things not getting done that everybody meant to get done, or things getting done that we thought we all understood this patient wasn't going to get. And the final thing I want to say about process and system change is that meticulous adherence to protocols, and I don't think I really have to emphasize this for respiratory therapists, but meticulous adherence to protocols can have remarkable effects on things like the incidence of ventilator-associated pneumonia, central line infections, surgical complications, and as we understand this, we really move toward understanding the importance of checklists, which I mentioned earlier. Checklists represent a commitment to a reliable process and a recognition, if you will, that we fallible human beings have trouble being reliable without some help. The checklist is also a statement of what we expect, which is very helpful because it encourages communication about what we're trying to do that otherwise may not happen. And finally, a checklist is a very simple way of checking whether we're doing what we intend to do. If there is no checklist, but there's supposed to be one, or there is a checklist, but it has a lot of empty boxes instead of check marks, we have a record that we have an opportunity to improve things. So the checklist is really quite important. If there is a single book I would urge you to read, it is Atul Gawan's The Checklist Manifesto. It is short. You can read it in less than 2 hours. It's extremely helpful in thinking about the role of checklists and the need for checklists. And finally, it is thin and inexpensive. So if we go beyond that, the next slide is going to show you an example of a patient-oriented checklist used by Anne Arundel Medical Center near where I live. This checklist enrolls the patient as a partner in making sure that the checklist elements are successfully carried out. And it's a very simple document. Checklists can be much more elaborate than this. They can be much more rigid about what you have to do. But the idea that a sheet of paper as simple as this could actually make a large difference often surprises people.
Dr. Jencks, is this something that you think the respiratory therapist can and should do using the checklists?
Well, respiratory therapists are well accustomed to the concept of checklists. I don't think that they have to be introduced to this, but I think they may well be not at all accustomed to their use in organizing and planning transitions from hospital to post-hospital care. And I think they can both be advocates. The people who are familiar with them are much better at saying these things actually don't bite. They're kind of helpful when there may be some skepticism from other people. And the second is that it can begin to frame the question of what's my job and what's your job in making sure that this patient goes home with everything they need to succeed. Yeah. So the answer to your question is yes, indeed. Now, I mentioned that the word discharge is a problem word, and primarily because it suggests that responsibility stops at the door. A young woman whom I know had a baby in the English National Health Service 2 years ago. And when she was ready to leave the maternity hospital, she was told that she was going home, but that she would not be discharged for a month because the hospital felt that it had a continuing responsibility and engagement with her. That is the antithesis of discharge as we've understood it. That change in attitude is, I think, one of the essentials in being able to move forward.
So as we look at this and we look at the team that are clinicians and therapists included that'll be part of this, I'd kind of like to get some thoughts from you, Becky, as to what your experience has been at Sanford. How did you do it? How did you do some team building there?
Well, I think the ideal of team and the interdisciplinary team is at the core of the program that we built. A hallmark of our program is that while this is a respiratory therapy-led program, we are the experts at providing respiratory care to these patients. It is the work of the interdisciplinary team and the support of the interdisciplinary team that has really allowed us to have some of the significant outcomes that we've achieved.
So I'd ask you then, how can we prepare to put this team together in the hospital? What are some of the key features we need to be concerned about?
Well, first of all, you have to make sure that you have good relationships intact already within the interdisciplinary team, the physicians, the nurses, the therapists. But you also need to be able to identify, number one, who touches the patient while they're in the hospital. All these people need to be around the table. And then you need to identify what outcomes you're going to be pulling, who you will ask to get that information from, and in other areas, who can support components of the program that you build. Identifying those people, having them on the planning teams, and having those contacts and relationships continuing as you go through the program are very important to building a program like this.
Dr. Jencks, I'd ask you the same question as well.
Yes, I think that I'd really want to underline what Becky just said, but to clarify something. The interdisciplinary team is not the team of the people who deliver the care. It is the team of the people who have the ability to make sure that the folks who deliver the care are able to deliver it in a coordinated way. I mean, Becky will show you a list of the people who participated. If all of those people had to have their hands on every patient, the hospital would grind to a standstill. The other part is that we're talking right now about building a hospital team, but it's really important to keep in mind that there are two other critical participants in this team. One is the community provider or providers who will be responsible for making sure this patient gets care. And the second is the patient, him or herself. And when we think about adding them, again, partly what we're saying is, what do we need to do to make it possible for things to fit together, rather than to have every single decision be a group decision-making process, which just won't work. One of the things that I think is important is to have people who have enough curiosity about what the other people who are involved in a particular care enterprise are finding, dealing with, having to find ways to pay for, not being able to get people to do. And that kind of knowledge and understanding of the situation of other people in the team is really important. And it's particularly important, for example, in dealing with management, where, for example, there's a really strong tradition of blaming the CFO for any resistance to change. And my experience is that CFOs are very anxious to prepare the hospital for moving safely into the next environment. And you have to understand that their major goal is to make sure that the hospital moves safely into that new environment and they don't get pushed off a cliff by somebody who's well-meaning but doesn't understand strategy.
Is there part of the team?
Yes, they are, and I think Becky will tell you that their continued enthusiastic support can be the difference between success and failure.
Absolutely.
So if we move on to the next slide, what we're going to talk about is, within the hospital, you need both the people who are caring for the patient's lung disease, their COPD in general, and you need the people who are caring for other parts of the patient's problem. Very few COPD patients are lucky enough not to have other major chronic problems. And so you've got to put together this disease-focused approach, this patient-focused approach, which looks at the whole patient's needs, and then this community relationship as the patient moves from the hospital into the community. You got to do it all. I'm sorry. It's hard, but it gets easier with time. The thing I'd like to bring us up on, if you can show me the next slide, please, is that it is easier to do disease-specific things that will help bridge to care in the community. I mean, if you have somebody who is a community-based RT, for example, that's an easy conversation to have. So the disease-specific part makes some parts easier. Other parts, not so much. I mean, if you want to change what kinds of medication lists patients get when they're ready to leave, you really have to have a hospital-wide solution to that. It's no point trying to do it disease by disease. So you have to do the whole thing. As the next slide shows you, you also need to know who will take care of your patient when they leave the hospital. I cannot emphasize enough the importance of human contact. Jane Brock, who's done a lot of work in this area, said the most important technical tool in making transitions work is coffee and donuts. And what she meant is, if you actually see the people that you're calling up or sending a patient to, it's a very different thing than if you actually never met or talked to them. I mean, take a sort of homely football metaphor. Nobody would ask a quarterback to throw the football to somebody he'd never trained with and never met. And the outcomes would be somewhat predictable if you did. Now, patients are not footballs. I want to be very clear about this, but teamwork is teamwork. And we really have to see that that's true. A few years ago, I worked with two major organizations to help them collaborate by finding work they could do together on reducing readmissions. After 2 years of work, both organizations were engaged in multi-million-dollar projects. They were not talking to one another. So there's more to getting people working as a team than just finding common interests for them.
So I'm picking up a theme already that communication is key to the success of this.
That's my belief.
So at the same time, are we talking about or maybe suggesting of expanding the team at the same time?
My view is that we need to have both an expansive and a focused view of the team. We have to have an awareness of the many people whose help or collaboration or at least non-interference is important to success. On the other hand, as I said before in building the hospital-based team, if you try to involve every single person, you just can't get the work done. It's paralysis by consultation. So let me just take the issue again of the patient's situation. Bringing the patient in as a partner is absolutely essential, and we all know it. We don't take care of chronic obstructive pulmonary disease. The patient takes care of it, and we either provide effective support or we don't. So when we say that a patient is non-compliant without taking the effort to understand whether they understood the plan, whether they had the health literacy, the mental clarity to do it, is, I think, it's demeaning and it's also self-defeating. That's not the way you make people your partner.
Sure.
And what happens then is we come back to looking at the problem of education. I cannot imagine a more difficult time to try to educate somebody on an important topic than when they were still recovering from an illness serious enough to hospitalize them, when they were under the influence of medications intended to benefit their pain and other problems, but also making them delirious in many cases. And when they really want to get home, so much that they will promise almost anything and claim to understand almost anything in order to get their release. And we really have to understand that only for a very few patients are you going to be able to educate in the hours or even days before discharge and have them remember with depth what the education was. They're just not at the top of their game. I remember being hospitalized a few years ago after a fall, and I'd been on OxyContin. I had a lot of bruises and fractures and things. Well, they sent me home on Tylenol, and my wife, who had not been present at the debriefing at the bedside, looked at me and said, "Steve, how did you let this happen?" And I said, "Well, I didn't see any problem about it. I mean, when you're on OxyContin, there are no problems." And so we just need to constantly keep in mind that this patient may have a slightly different agenda from our agenda and a slightly different mental status from our mental status. The idea that we can change the conversation by reducing the use of unnecessary is, I think, quite important. If we say we are going to look at every readmission and see whether there are things that could have been done to reduce the risk, I think we're on absolutely solid ground. If we say all readmissions can be avoided, in the first place, we completely lose credibility with clinicians. And in the second place, we're just flying in the face of where things are right now. So the key feature is to say, gee, this wasn't what was planned. And is there a way we could have avoided that?
So to that point, then, I would ask you, is it realistic for us to expect 0 readmissions?
I don't think it's realistic for us to expect it very soon, which really means not at all. But what I do think is that we do not hurt anybody by saying that number is higher than it needs to be, and we can get it down, and we should regard it as a joint enterprise to do so. And I think that sometimes that involves a part of care planning as well. Because if you have a patient with COPD, it is most unlikely that an emergency admission to the hospital was the high point of their week. And we need to understand as well, and this gets to sensitive ground, but important ground, that very few patients have a desire to die in the intensive care unit of a hospital. So there really need to be some crucial conversations that take place. We cannot let the fact that those conversations have not yet taken place prevent our doing care planning with the patient, but we should be aware that that's a part of doing things well. At this point, we ought to just stop and think a little bit about the care plan as a document. This is a document which is designed to be shared and to help to knit together the people who need to work together. And it documents the aims of care as well as the specific things such as drugs, physicians' appointments, and it finally gives information of the kind that we discussed when we talked about Eric Coleman's pillars. That is, for example, if you look at the next slide, one of the things that it should rest on is crucial conversations that may not have taken place. Okay, I mean, we all want those conversations to have taken place. They may not have. if they have not, it is not a reason not to have a care plan. It's a reason to plan to have the conversations. But what is crucial is that there be something that the family, the patient, the physicians, nurses, RTs, community people can look at and say, yes, this is what we're working together to do. And it includes questions like the ones on this slide. What are the serious problems? The red flags, whatever you call them. What is the major medical problem or problems that I'm dealing with? What are they called, but what are they? What do I expect my care to accomplish? Do I expect it to ameliorate my discomfort? Do I expect it to cure me? These are things which do not always get done. And building those care plans is a really important part. If the checklist is one part of how we get there, the care plan is the way we make the checklist a human document. So let me try to summarize this in terms of 4 tasks that I think are worthy of your attention. Tasks for the coming week, if you will. The first of these is talk to your colleagues and understand what you think you're doing, and really consider having a discharge checklist, a transition checklist, so that you can see whether you're doing it. I warn you that this may be a slightly uncomfortable process. Almost everybody thinks the data are in error when they first look at them. The second thing I would urge you to do is to talk to the people who will care for your patients when they go home. And some of the time this is going to be uncomfortable for a different reason, which is you're going to find pushed in your face the fact there isn't anybody who's going to provide this care for your patient. But I think that that is one of the things we really need to know if we're to take care of patients rather than just spin fantasies of, well, they're going home and somebody or other will take care of them there. The third also has to do with communication. Talk with some of your patients who have been readmitted. Talk with them in a very open, listening way about what might have been done better or differently that would have perhaps helped them to stay out of the hospital. And fourth, and I think really at the core of what we're trying to do, remain hopeful and remember that we really have an opportunity to improve care here. It may seem mostly like a challenge, but it's a huge opportunity. Thank you.
Thank you, Dr. Jencks. That was a great overview and a great summary. And I'd really like to transition over now to Becky so we can talk about real life experiences in Fargo, North Dakota.
Thanks, Tom. Well, the inpatient COPD care program at Sanford and Fargo really began in 2007 when our vice presidents came to the department directors and asked them to take a look at the medical DRGs. We were losing money on the medical DRGs, which is not unusual for hospitals across the country, and they wanted the directors to identify some cost reduction strategies. So the director of respiratory therapy thought that we could really have an impact on the COPD patients. So he was assigned to take a look at this service line. The first thing he did was get a service line and MS-DRG analysis of the COPD DRGs, which are 190, 191, and 192. And what he found is that we were losing about $615 per patient admission, and that our length of stay had risen slightly. The other thing that was in place is that we had a 5-year plan, which included strategies for chronic disease management. We wanted to use evidence-based guidelines and clinical practice standards to build our care programs. We wanted to look at the application of evidence-based care, and what we knew is that there was no standardization for these patients. There were no clinical pathways, no standing order sets. When the patient was admitted, generally the physicians chose the orders and the care based on their background, what they knew concerning care for COPD, but nothing was standardized. And this this concept of ideal care, which we'll discuss a little more in depth in a few minutes, ideal care at Sanford occurred only 34% of the time, which was actually at the national average. So evidence-based care was not in place. When we began looking at this in 2007, we weren't talking about readmissions. That would come 2 years later, but it was on the horizon. And when we went back and looked at this period of time, we found that our 30-day all-cause readmissions for COPD acute exacerbation was at about 28% as we were beginning this program. So with this data in hand, the evidence that we were losing money, that quality of care was not where it should be, the Vice President directed Respiratory Therapy Director to go ahead and pull together a group to assess how we could accomplish this improvement in care. So what he did was pull together across the health system the people who either supported work like this or the people who actually, as we talked about, were involved in the care of the patient. We included the physicians, the pulmonologists, who are also our medical directors. The head of the hospitalists was involved. One of our intensivists was involved. We also pulled in the nursing units. We have 2 medical units, and from one of the medical nursing units, we had the nurse manager involved in this work group, and we had a social services representative from the other medical unit. Those 2 entities later became case management. So we had the background of having their involvement from early on. We also wanted to involve a clinical pharmacist. It was important for us to make sure that when we were looking at care, we were looking not only at cost, but also looking at the correct treatment, the most effective treatment, pharmaceutical treatment for these patients. Of course, respiratory care was involved, including pulmonary lab and pulmonary rehab, the staff managers. We also pulled in the people from whom we would be asking reports be delivered, including finance and quality, utilization review. We wanted information technology and clinical informatics involved from the very beginning so that as we progressed in through our electronic medical record that we had components built that would support this work. So really, as I said before, a hallmark of our program is that we looked across the organization to help build this program.
So as you did this, what were your set goals?
Well, our set goal was to standardize inpatient care for COPD using the evidence-based guidelines, and they defined 4 objectives. The first objective was to create a brand new position of a respiratory therapy case manager who would oversee the program itself, who would facilitate the interdisciplinary team, but who would also align with the patient and work with the patient and the patient's family in making sure that their story was heard and that we could have smooth transitions of care. They also knew that we needed to develop some standardized tools, including an admission order set, a medication protocol for respiratory therapy. At Sanford, we had been working, the respiratory therapy department had been working under a protocol system for over 20 years, so we knew our therapists would not be intimidated by this process. It was surprising to us, looking back, that we did not already have disease-specific medication protocols in place, but we didn't. We knew this needed to be addressed. We also wanted to make sure that we were pulling information about our processes and measuring and reporting outcomes. We wanted to make sure that the data that we pulled was easy to access, timely, so that we could respond with quality improvement as quickly as the information gets to us. So we pull information about recommended and non-recommended cares, which we'll discuss. And of course, we wanted to reduce costs, so our financial information and net margin information is very important, looking at length of stay and readmission rates.
So is it fair to say that if you build it, they'll come?
No, not at all. What was clear was that because of this inclusiveness of our work group and the work that the interdisciplinary team did, there was lots of support. And as they went through the process, there was very clear communication to the staff, to the physicians, to the therapists, to the nurses about where we were in the process, what the final product was going to look like, and what all of our responsibilities would be within this care program. We also, upon initiation, needed to go back to all of those services and talk about specifics with the physicians. There's an admission order set. Here's how you access it. With the therapists, talking about the protocol and how they move through it, what the expectations were. So the first objective was to develop a brand new position for the respiratory therapy clinical specialist. This position was tasked with facilitating the interdisciplinary team, but also with working with the patient and making sure that their story was heard, that their concerns were met, and that we were able to identify what needed to occur before discharge so that we had safe transitions. And the clinical specialist really works as a physician extender and a patient navigator. Their job is to identify the inpatients, to facilitate the work of the interdisciplinary team, make sure the physicians are ordering the recommended cares, and if not, to understand why so that we have a good grasp on what the care plan is and how respiratory therapy and the rest of the care team needs to do that work. The clinical specialist also partners with the patient and their caregivers. Very important to have information flowing to and from the patient and the people who support the patient. The clinical specialist needs to identify and resolve transition barriers. Now, part of identifying and resolving transition barriers isn't that we are telling the patient what to do, but rather we're hearing the patient's story. And when we talk about communication, there is a classic concept developed by Dr. Miller called Miller's Law, which says that when we communicate with people, we need to set aside our preconceived notions, and we need to really listen to understand. We need to think that what the patient is telling us, what this person is telling us, is their truth. And if this is the truth, then what could cause these things to be true? So we're really listening to the patient, really letting them tell their story, and working from there to resolve any issues for transition. The clinical specialists also provide patient education, and as Dr. Jencks stated, patient education in the hospital is not really the best place for this to occur. However, we need to make sure we send the patient home with at least basic knowledge of their disease process, of how to take their inhaled medications, and of who to call if they have questions once they're discharged. Communication post-discharge is very important. We do follow-up calls with the patients post-discharge. And we also review outcomes data. And it's the job of the clinical specialist, number one, to assimilate that data, to report it and to analyze it and report it, and to report it back to our COPD executive team, who now oversees this program.
A lot of the studies that I've looked at through the years that have to do with this type of a disease management situation is those follow-up calls and the contact with the patient. As Dr. Jencks mentioned, you know, you're in the hospital and you might not be in the best position to learn things, but it's an ongoing continuum. And I think I applaud you for having the capability for patients to call you and for you to reach out to patients. I think that's key to any success.
I think it is key, and I think it's also key that we do this in an interdisciplinary setting where the nursing staff knows that we're contacting the patient.
Right.
If they have questions that need to go back to the nursing staff, there's a pathway for that, so that we make sure that the patient's questions, that the patient's concerns are not lost after discharge. So that is an important point. A second component that we wanted to look at, of course, was the evidence-based care. And as we said, there was no standardized care when we began. The first thing we needed to do was look at the literature and what was already out there about inpatient care for COPD patients. And there are quite a few different resources that we pulled in. But to build several of our tools, we relied on evidence that had been published. The first piece that we looked at was Dr. McCrory from Duke University and his associates published in CHEST 2001, where they did a search of the literature and pulled together information about what had been deemed to have positive outcomes for patients and which care lacked evidence for positive outcomes for patients. And they identified that efficacy existed for chest x-ray, for oxygen therapy, bronchodilator therapy, systemic steroids, antibiotics, and for non-invasive ventilation when it was needed. What they found was that there wasn't really much evidence that showed the list on the right to be helpful in outcomes for the patient. Sputum analysis, acute spirometry, of course we don't do spirometry in the hospital. Spirometry generally for diagnosis is done either on initiation of treatment or when the patient is in a stable phase of their disease, not in the hospital. Mucolytics aren't helpful, chest physiotherapy not helpful. So a whole list of things that are not helpful. So the therapy for which evidence exists, they titled recommended care. The therapy for which evidence was lacking was titled non-recommended care. And non-recommended care is really unnecessary care. It adds cost for both the patient and the hospital and does not improve outcomes. The second piece of information that we looked at was a study by Dr. Peter Lindenauer and his associates that was published in 2006. Dr. Lindenauer and his associates published a study, a retrospective financial review of over 70,000 patients in 360 hospitals. And they were looking at adherence to the diagnosis and treatment recommendations from ACP and ACCP, which Dr. McCrory had referenced. And what they did was they took the financial records and they identified recommended and non-recommended care from the charges. If the patient was charged for oxygen therapy, they received oxygen therapy. The overall results were that 66% of patients had received all of the recommended cares, 45% of the patients had received at least one of the non-recommended cares, and only 33% had received ideal care. We wanted to replicate the Lindenauer study to take a look at where we were with providing evidence-based care. And so our respiratory care students from our bachelor's degree program took this on as a senior project, and they reviewed the financial records of 288 patients who had been hospitalized in the previous 18 months with acute exacerbation of COPD. They took a look if there was oxygen therapy charged, the patient got oxygen therapy, and the results were that we were less than the national average in adherence to recommended care. We were better than the national average in not providing non-recommended care, and we were just average in providing ideal care, which is described as having all of the recommended cares and none of the non-recommended cares. So we were average. We do not aspire to be average.
So based on this information, how did you put this into practice?
We needed to build, first of all, some tools, some checklists, if you will, to make sure that what we wanted to occur was occurring. And the first tool that was built was the COPD admission order set. We wanted to make sure that we included the recommended cares, which were the evidence-based cares. And those included oxygen therapy, chest x-ray, bronchodilators, steroids and antibiotics, which the evidence shows reduce treatment failure, decreases mortality and length of stay. And what else we discovered was that oral was effective as systemic. This was important to us because, again, one of our primary objectives was to reduce cost. And what we know is that IV steroids and antibiotics are 10 times the cost of oral. So we wanted to use oral when we were able to. We also wanted to be very aggressive in treating exacerbation, and being aggressive means having non-invasive ventilation on standby so that we're able to respond as quickly as possible if the patient appears to be headed towards acute respiratory failure. So we developed a protocol for non-invasive ventilation, and we made sure that this item is included in the admission orders. It's an as-needed order. We don't need to do this, but all of the specifications are in the order set. We know that non-invasive ventilation reduces the need for intubation. Intubation and mechanical ventilation are the leading indicator for mortality in the hospital, so it's no surprise that the use of non-invasive ventilation decreases hospital mortality. It also decreases length of stay. We wanted to include consults for the respiratory therapy protocols to make sure that the therapists were able to respond with appropriate therapy as soon as possible. Also, we wanted to make sure that a consult for the respiratory therapy clinical specialist was placed so that they were able to identify the patients early and they were able to start the work of transitioning the patient, of identifying barriers to transitions right away. We have a tobacco education order if the patient has used tobacco in the last 12 months. Our tobacco treatment specialists, respiratory therapists specially trained in tobacco education and motivational interviewing will see the patient. We also have an order for a pulmonary rehab referral. Pulmonary rehab reduces hospitalizations, reduces ER visits, and improves quality of life. And one important component of pulmonary rehab is education. So we began the basis of education in the hospital. It is then continued post-hospital in the pulmonary rehab setting, and the patient receives some of those same messages about self-care in pulmonary rehab. We also want to include nutrition services. Many times readmissions are actually caused by poor nutrition post-discharge, and with the COPD patient that's especially important because we know that their mobility and their ability to make their own meals, to actually have the energy to eat post-discharge is sometimes not always there. Case management, as I said, was involved from the beginning, and generally these patients receive a case management consult. They're complicated patients with complicated discharges. Again, the respiratory therapists are not part of that case management team, but work in conjunction with case management. And of course, physical therapy and occupational therapy, the therapy surfaces as needed. And when we take a look at our outcomes for adhering to patients receiving the evidence-based care, we can see in 2008, 57% of our patients received all of the recommended care. In 2013, we were up to 97% adherence to patients receiving the recommended cares.
Could I make a comment there? There's a point where you worry if people are adhering too closely to protocols. It's often hard to know what that is, but it's worth sort of saying, you know, you get up to 97%. I wonder if there were one or two people who got various treatments because it was on the protocol rather than because it was clinically indicated in their particular case.
Actually needed. I think I would agree with that, and I think that's a next important step for us to go back and review this. Because again, this is about not providing unnecessary care, and not every COPD exacerbation needs antibiotics. So I think we really need to go back and evaluate, and perhaps this measure itself is not useful in the way we need it to be useful. That's a good point. We also want to take a look at our pulmonary rehab outcomes. Again, I said pulmonary rehab reduces hospitalizations and ER visits. And the way that we measure this is we take a look at hospital admissions for 6 months prior to a patient being admitted to a pulmonary rehab program. We then compare it to hospitalizations and ER visits for the 6 months after the patient was discharged from phase 2 of pulmonary rehab. And this really goes to knowing what your data is telling you. You can see we go back and forth. In 2011, we had our best year. We had a 75% reduction post-discharge compared to admission to pulmonary rehab. In 2012, that went down to a 33%. And in this case, there were patients, 3 patients who were at the end of their life and had multiple readmissions to the hospital. So when we look at improving pulmonary rehab, we have to look at those individual components of what's involved in these, this data and make sure that we're not reacting to something that doesn't need an action for, but really understanding our information and acting on improvement where improvement should be made. The other piece that we developed to help in evidence-based care was the respiratory therapy COPD medication protocol. And our goal is to provide bronchodilator therapy for these patients with the frequency and dosing based on patient symptoms. So when the patient is admitted to the hospital, we discontinue their home inhaled respiratory medications. That doesn't mean that it wasn't an appropriate regimen. It just means that the patient is hospitalized and that regimen was not working. So our goal is to be very aggressive in getting the exacerbation under control, and we gain rapid control by use of the short-acting bronchodilators. Once the patient is under control based on their dyspnea level, based on their breath sounds, based on what the patient reports their dyspnea level to be, and the respiratory therapy assessment, we will move to the long-acting bronchodilators. And there are some benefits of using long-acting bronchodilators in the hospital setting. Our research shows that we have a reduction in the number of treatments per admission when using long-acting bronchodilators. Why is this important? Because care costs the hospital money and care costs the patient money. So if we can really look at refining and giving evidence-based care, which includes reducing unnecessary treatment, that's important. There are also fewer adverse events related to the long-acting bronchodilators. A study by Dr. Coleman showed that the use of formoterol reduces healthcare resource use and adverse events for patients hospitalized with asthma and COPD. And there was a study that showed that early use of tiotropium for patients with acute exacerbation reduces length of stay and cost. So really looking at the evidence and building some of those components into our protocol. The other thing that we wanted to look at was the cost of the specific medications. Because off the top of our heads, if we think about it, we know that some medications are way more expensive than other medications. That doesn't mean that they aren't effective in treatment, and it also doesn't mean that that is the single reason we should not use a specific medication. What we did was ask our pharmacy to come up with a list of our formulary for inhaled respiratory medications. We took a look at the medication cost. That was broken down by unit dose. If it was an MDI, it was broken down by puff. If it was a DPI, they come standard packaging, so you pay for the entire cost of the DPI. And we broke it down by cost. You also have to take the labor cost into account. And our costing department was able to tell us that it costs the hospital about $20 per treatment to provide respiratory therapy to patients. So when you look at that labor cost, and you look at the supply cost, and you look at the total cost, providing short-acting bronchodilators is actually more expensive than providing long-acting bronchodilators. That doesn't mean we should not be using either or. It just means that you really need to know what your costs are, down to the very minute detail. It was important for us to identify, again, the correct classifications of medications to treat this patient. We weren't simply concerned with cost savings. We were looking at getting the exacerbation under control and keeping it under control. That was one of our cost-saving maneuvers, and also evidence-based care. When we look at our financial outcomes, we can see that we went from a negative net margin to a positive net margin, and our latest data shows that we now have a positive net margin of approximately $1,000 per patient stay. What that means for us is that we have over a $200,000 swing in our net margin from where we began per year. Now, as I talked about in the beginning, readmissions reduction was really on the horizon. We hadn't heard much about it. But when we went back and looked at our readmissions, what we noticed is that as we began the program, our readmissions initially declined. This is looking at 30-day all-cause readmissions, which is what CMS is measuring, all-cause readmissions, the patient coming back in for any reason. On this graph, Sanford is the blue bar, and the comparison group is the top decile of Crimson users. We use Crimson. There are other databases that hospitals use to give them readmission information, but for the most part, we have been at or below the top decile. You will see in 2011, we had quite a significant spike. The yellow triangles will show what the data would have looked like if we had not had just 2 patients who were admitted repeatedly throughout the year. One patient had 31 ED visits and 12 hospitalizations in 1 year. Both of these patients were very challenging socioeconomic statuses. We got their care under control, and the next year they had much fewer admissions to the hospital. Again, very important to know what your information is telling you. Now, it's very hard actually to stratify these patients, to know who the frequent readmitters are, but I think in our experience, that is one group who tend to be high readmitters, is those that are homeless, those that have chemical dependency, some of our immigrant populations where communication is an issue. We really need to focus in on serving that patient population better. So when I talk about our program and I talk about what has really brought about some of our success, I think that an important first step is that we must align with the strategic initiatives of our health systems, of our hospitals. That's where you get buy-in from administrators. They are the people who are defining where we're going, making sure we go there safely, making sure we get there in the future. And certainly, one of the strategic initiatives that every hospital should have identified is reducing unplanned readmissions. We also want to collaborate across disciplines and departments. This is an opportune time for respiratory therapists to elevate what we bring to the table and to really work in an interdisciplinary setting, in a supportive setting that really meets the patient's needs across the health system. We also need to develop IT systems that support this work, that we're moving towards a system that is electronic and not part paper, part electronic, a system that can be accessed by all care providers across the health system. We also, I think, a key component of this program is the employment of the respiratory therapy clinical specialists who are really case managers who oversee the program. Our hospitalists will tell you that this program is not self-sustainable if we take away this person, the person who oversees the program. We also must partner with the patients and the caregivers. Probably the single most important thing is that they are helping to identify their care plan, that we're listening to their story, that we're understanding them, that non-adherence is mostly the fault of the medical practitioners and not the patient. We also need to begin comprehensive transition planning on admission, not 1 hour before discharge. This is a process, and these patients are very complicated. We need to use evidence-based care. We don't need to provide care that not only is not necessary, may have implications for safety for the patient, but also adds cost to both the hospital and the patient. We need to communicate with post-acute providers across the system. We need to make sure everybody has the information they need so that this patient can transition across the system. Because again, health systems are very complicated, convoluted systems, and if you don't know the pathway to get where you're going, you probably won't get there. So we need to make sure that that pathway is very clear. Provide post-discharge follow-up. This has been shown in numerous studies to have significant outcomes on several areas, including readmissions. We want to clear up any items that were identified as possible problems when the patient left. So we want to ask those questions. Will you be able to get to your physician appointment in 5 days? Were you able to get your medications? Were there any problems along this area? We also want to utilize outcomes data. We want to collect data, understand what it's telling us, and utilize it to improve our processes and to improve our quality.
And some of the things that we can do to teach therapists about that is we have the Leadership Institute at the AARC, where we can train up managers and researchers and educators to be on par with their peers in the hospital. Yes. You know, the challenge is really on us now. And in fiscal year 2015, October 1st of 2014, there'll be the penalties for readmissions within 30 days. And respiratory therapists have an opportunity, as I'd mentioned before. And we need to work with our team. I've heard the team bantered about, and about communication, essential. We need to work with our medical directors, our staff, and our hospital administrators, and really have the courage to do what you did and others are doing around the country now. And I say that because we opened up something called Best Practices, and it's on our website, aarc.org. You can go to this box that says that, and in there, you'll find not only your information, your protocols, but others who have done this as well. And I would encourage the respiratory therapists who have an interest in being part of this, and I hope it's everybody, to go to that website and to learn from others. You don't have to necessarily reinvent the wheel, but you can use some of the things, the tools that have worked for others. I'd also alert you to go to your April issue of 2014 of the AARC Times. In there you'll see an article written by Dr. Stephen Jencks, which really gives an overview of the problem and about the opportunities for respiratory therapists. So I really appreciate both of you being here, sharing your knowledge and experience. And from the AARC, I just am so grateful that you spent that time with us. And I'd like to thank you for joining us for today's program. And again, I would urge you to move forward and to reach out and to start programs like this, or be part of programs like this in your hospital and community. From the AARC, we'd like to thank you.